Well, hello everyone. We're here today with Kenneth Kaitin from Tufts University and Luca Pani from University of Miami and former IFA's Director General. And we're talking about the sustainability of healthcare funding initiative that we as DIA work together with the Boston Consulting Market Access Roundtable Group. I want to start with asking, why are we doing this initiative and what's the importance for DIA, for the society, and what we're trying to establish?
Well, I could start. There have been clearly breathtaking advances in our scientific understanding of disease and disease mechanisms, which has led to a wealth of new opportunities for pharmaceutical companies to develop treatments for diseases where there were no treatments in the past. But the real challenge is the affordability and the access to those medicines. And it's critical at this point, I think, for industry and for all the stakeholders to get together and to figure out a way to ensure that these wonderful, innovative medicines that are coming to market are affordable to the patients who need them and accessible to the populations that have been looking for these medicines and waiting for them for perhaps their entire lives.
What about you, Luca? What do you think?
Yeah, absolutely. I have to echo what Ken was saying. We had, and we still have, a very interesting gap between the technologies that were growing up in the medical space, from the monoclonal antibodies and then speed up. Now we have the CAR-T, the small interference RNA, the CRISPs, all that. And instead of the kind of primitive, sorry to use this strong word, but way of what is the pharmacoeconomical value for this. It was like the two worlds were separated. So we have this very innovative medicine eradicating disease, as Ken was saying, that deadly disease, and how do you pay for this, how do you sustain? And the model was like, okay, like the old times. Hey, wait a second, but this is a one-shot only, $500,000, $1 million, and the rest were completely different. Oh yeah, we didn't talk about it. So now and we have to really get together and get something, that we don't have the solution, but clearly if we don't come with a solution, then the sustainability of the entire system is in jeopardy.
Yeah, we see a lot of issues in Europe, either with the value and the payment system, legal frameworks are there, and also in US in terms of the interest, I guess, in the system, that who gets to win if there's a cure, whether hospitals, etc., what happens to them. I want to ask, Ken, you're leading the cross-stakeholder engagement stream for this initiative. Like, what are the key points on that stream that you think should be solved?
Well, the main issue is the assessment of value. And for years, I think the model was that a drug was brought to market, and the industry waited until after the drug was on the market to do sort of market-oriented studies to get a sense of what the value of this drug is. Physicians would use it in practice and they'd make their assessments based on the use of the drug. But I think today the demand is to get as much information as possible before that drug reaches the market, so that the payers and the insurers can have a better understanding of how that fits into the overall affordability of the drug supply. And so from a patient perspective, it's clear that their input is going to be necessary to make those determinations about value. I mean, when you think about it, it's almost silly to think that industry or any other stakeholder can determine the true value of the drug. It's the patient that's taking the drug and has to be able to make that assessment. The challenge, I think, the key challenge, and what we're trying to accomplish in this working group, is to understand how to gather that information, how to engage patients so that they can make those assessments, and basically how to teach them the language of value, how to teach them how to interpret the responses they're looking for so that they can be a contributor to the discussion about the assessment of value. And that's what we hope to accomplish.
How do you see the payers and the other actors in the system? Would they be welcoming that the patients would be more involved?
Well, I don't want to make it sound like only the patients have a challenge. The payers and the developers have a challenge as well, because they're not used to listening to those stakeholders in these determinations. I think from the industry standpoint, even the determination of value is going to be a challenge because there's no real definition of value. And there are no real mechanisms for giving a precise a number that represents value. So now to bring in another stakeholder just complicates it. But I think it's absolutely mandatory that we start the discussion now of bringing these stakeholders together so that we can come to a common understanding of the best way to assess what value these medicines bring and how to allocate scarce resource dollars to ensuring that those drugs and those medicines are available.
And talking about patients, I think we have another stream on payment models, and that's of course very relevant for the patients as well because they're co-payers, etc. So how do you look at that stream to turn out, and what are the key points there?
Well, first of all, let me mention a fact that you say passing by. We clearly need some legislative hook to do all this, because as you know, being European, if we don't have something to attach all this that has normative value, is going to be very difficult. And even in this country, when you move, for instance, on the payment model on CAR T, and then the patient can go with another provider, well, a gene, one is in your body, you cannot take it out. So it's luckily so. And if it's working, who is paying? Me that I close the contract or not? So that is already an issue in the system of payment. The second, as Ken was saying, is that this table of stakeholders is not too large. It's actually a small table, but it's very heavy represented. So you have patients, you have healthcare providers, whatever you want to call them. You have the industry, of course, there is development of drug, then you have regulators and payers in the table. Not that the payers are somewhere else and say, okay, when everything is finished, I'm going to put the price, because then the price can be very high and you don't know what to do. And then I come to your question on what we have recently published in this Sesifo paper with Iris Nober, Siddharth San, Valentina Mantua, and Telazzozi on the so-called three-part pricing model, which is basically a model on which patients are asking, rightly so, that some of these products arrive very early when we don't have established everything in terms of the risk and benefit. So there are also, again, some legislative issues. We can become medical and legal, but let's say that under controlled circumstances, under conditional approval, we go in early, 3 to 5 years. The adaptive models, the prime, the adaptive, but it's also an adaptive reimbursement model. So you come very early and you start building all the evidences that you need to get some sort of efficacy and safety and pricing. Once you have agreed on those in a contract, negotiating, binding contract, you have a time lag of about 2 or 3 years, and then you have a price that steps up if the conditions are met, okay? And then on that, you apply the classical management entry agreement scheme. You want to do risk sharing, cost sharing, payment by results if you have not really got the biomarkers. And then after a while, you go down. And why you go down? Because now, that's another thing that has changed with these drugs. You have, thank God, long-term survivors. And these long-term survivors have changed the so-called Kaplan-Meier. The Kaplan-Meier is now really a survival curve. 15%, 20% of these patients go on for many, many, many years. What is the model for paying that? Because every year another 15, 20% adds on. So it becomes unsustainable and also very difficult to add up in the books of the company of what will be the revenues. Mm-hmm. So all these things together, again, we don't have the solution, but we need to put this onto this table and come up with some ideas.
Yeah, certainly. And another point I wanted to pick up is on the provider side, as you mentioned. It seems to be they're not a part of the discussion at the moment, I feel like, and perhaps some of the issues, the uptake is there, and the CAR Ts, we know the issues as well, that perhaps the business models doesn't marry up with the CAR T idea. How can we solve that issue?
I think the providers have really been left out of the discussion, and in a way, they really haven't worked to inject themselves into the discussion. Physicians tend to, with all due respect, they tend to be concerned and complain about the high prices of drugs, and yet they're not engaged in the assessment of the value of those drugs,
right,
except in their personal practice. And I think it's absolutely incumbent on the medical profession that if there's going to be an allocation of resources that's based on a fair assessment of value, that the physicians, the providers, are engaged and involved in those discussions. And I think that we haven't gotten there yet.
Right.
And I think part of that is just the basic training. Medical students aren't really taught this, so they enter medical practice, they're not given any training in this. This has to be incorporated into a medical curriculum so that physicians, when they reach their practice, are fully involved and understand the process and can be an active participant in these discussions.
That's right.
I agree. But any final points on that?
Well, I think one of the possibility of doing this is to work around the avoided costs. So this value able to avoid some costs down the line? Are you able to quantify this avoided cost? And are you able to put this avoided cost that you measure into a contractual agreement? Now, the emerging technologies on sensors, anything in real life, the measures, so whatever you do in terms of how much you walk, your heartbeat, and you name it. There's an app for everything, basically. I'm not sure we are in prime time for that regulatory-wise. The regulators will be a little difficult. Even being a very visionary regulator will be difficult to get all the places, the anti-corruption of the data, the CDIS compatibility, all these things. But for payers, that can really work, because a GPS tracing you to your place of work or your distances in whatever you do in your household, you're able to move independently, for instance, and then you can link the medicine to avoiding the cost for an helper, for anything else that will otherwise have to pay to sustain your daily life. Okay, that thing, so linking basically the real world evidence that you'll be discussing even here at the DIA, it's really important in the avoided cost and in the value of medicine. So that is the picture. Again, we need to really get some consensus from the different stakeholders, because everybody will have his own take and has to be taken into account.
I was just going to mention that's such an important point, and I think that's part of the issue there is that there's a structural problem in the way budgets are allocated in hospitals and by payers.
That's true.
So, for example, in my hospital, there's a pharmacy budget, there's a hospital bed budget, there's a physician budget, and so it's not uncommon to hear hospitals say things like, we've been able to get our hospital costs down, why are our prescription drug costs going up? We should be able to get everything down. And it's the exact opposite. It's the rising prescription drug costs that are lowering, but often that's just not perceived by the finance people at hospitals. How to take a more holistic view is basically what you're saying, so that you're looking at all of the costs of the disease, not just the cost of the medicine, but all the cost of not being able to go to work, and the cost of not being able to play with your children, or not be able to exercise or swim or whatever you do. All of that has to be taken into consideration, but also the opportunity to lower costs in the hospitals, other surgical procedures, physician costs, and everything else.
Yeah, so the disconnect between the budgets and the payment lines, I guess, like if you talk about the ward and the nurses, etc., what does it mean if you have a slightly more expensive drug here? Can you reduce FT somewhere elsewhere? What could help us in looking at like this totality of the cost and the modeling or the health economic models that the companies are presenting as part of their data and evidence? Would that be a solution? Is there anything we can do there, or should it be something else that happens? Is it on the hospitals alone, or?
Well, we have to go out from the silos type of mentality.
Exactly.
Because basically, look, let me be very brutal. If this thing does not affect my budget, therefore my end of the year premium of my own, then why do I care about this going up somewhere else? You know,
exactly right.
It's a typical example. I'm a psychiatrist about antipsychotics long term. If I treat you with the long-term antipsychotics by injection, I would not see you in the hospitals, except that is not in my budget. You know, you being admitted to the hospitals with an admission process that is very heavy for the families, for the patient, a lot of sufferance, a lot of costs, is not a problem of mine. For me, giving you drops of a very old antipsychotics costs nothing. And so my budget is checked. The problem of the hospital is your problem. Then we need really to change this, because otherwise it's in human nature. I try to have my own reward.
Yes. Well, any thought there? How could we change it in hospital level somehow?
That's going to be a slow process. I mean,
Very
it's critical, but actually I think we're unfortunately going in the opposite direction. As there's more focus on budgets, there's more siloing of budgets. So we need to break that barrier, break those walls, and get the people who are involved in this to think in a more holistic way. That's the only way to solve this, is to view this as a holistic issue.
So I'll stop there. Thank you, Luca. Thank you, Ken. And thank you all of you for joining us. And we're going to continue the discussion today.
Good to be here. Thank you.
Thank you.